Imagine a highway that processes, roughly 8 to 9 liters of fluid every single day.
Which is a massive amount of traffic.
Right, it's huge. Now, picture someone dropping a massive concrete barricade across all the lanes. But the pumps, they just keep pushing more and more fluid in behind it.
Just endless backup.
Exactly. The pressure builds, the concrete starts to crack, and the surrounding infrastructure gets completely starved of resources. Today, we are looking at one of the most destructive mechanical failures that can happen inside the human body. We're taking a deep dive into the pathophysiology of a bowel obstruction.
And this is, a surprisingly critical topic for you to understand because on the surface, a blocked gut just sounds like a basic plumbing issue. Like a pipe gets clogged, you unclog it.
Yeah, you take a laxative and you're fine.
Right, but diving into the medical texts and the pathophysiology research reveals this highly volatile, complex cascade. When this particular transit system fails, it can turn deadly in just a matter of hours.
Wow.
Hours. Yeah, so our goal today is to look at the mechanics of that failure, the history of how we learned to treat it, and why a routine surgery you had maybe 20 years ago might suddenly make you vulnerable to this crisis today.
It's wild to think about. But before we get into the catastrophic failure of this system, we need to clarify what a blockage actually means in this context. Because going through our sources, I found that the medical definition of an obstruction is fundamentally split into two totally distinct categories.
It really is.
Let's go back to that highway analogy.
Yeah.
In one scenario, you have a literal physical barricade that has collapsed across the road. A bridge has fallen or a boulder is blocking the lanes. Like, nothing can get past.
Right, and that physical barricade is what we call a mechanical obstruction. Something tangible is actually in the way.
Like what exactly?
Well, it could be a fibrous band of scar tissue pinching the intestine shut from the outside. Or it could be a tumor growing inward and taking up the space. Or, it could be a segment of the intestine that has literally twisted on itself, kinking the hose. The physical road is blocked.
Okay, got it. But the second scenario is completely different. The road itself is wide open. There's no boulder, no fallen bridge. Instead, it's as if all the drivers on that highway have suddenly fallen asleep at the wheel. The vehicles are just sitting there, completely stalled out.
That's a great way to put it. In medicine, that sleeping driver scenario is known as paralytic ileus, or a functional obstruction.
Functional meaning the structure is fine, but the function is broken.
Exactly. The bowel lumen, the inside of the tube, is completely clear, but the smooth muscle wall of the intestine has just stopped its normal rhythmic contractions. The transit system has essentially powered down.
Why would it just power down like that?
We often see this happen in the aftermath of abdominal surgery or as a reaction to severe infections. Sometimes heavy opioid medications or even extreme electrolyte imbalances can cause it. The physical pipe is clear, but the motor is just dead.
The tricky part here is that from the patient's perspective, a mechanical barricade and a functional shutdown, they feel almost identical.
Oh, complete.
You get this massive abdominal distension, severe vomiting, and an absolute inability to pass any bowel movements or gas.
And that shared clinical presentation is exactly why diagnosing this was historically such a nightmare for doctors. Up until the 20th century, before they had access to plain X-rays or CT scans, they were diagnosing in the dark.
Just guessing, basically.
Yeah, pretty much. They used the word ileus as a catch-all term for any severe intestinal blockage because they simply couldn't tell the difference between a mechanical block and a functional one, not without cutting the patient open to look anyway.
Which was super dangerous back then. Actually, I was reading about a specific condition from 1948 that really highlights this danger. It was documented by a British surgeon named Sir William Heneage Ogilvie, and it is like the ultimate medical fake-out.
Ogilvie syndrome.
Yeah. A patient with Ogilvie syndrome will get an X-ray, and their colon looks massively dilated. It looks exactly like there's a huge, life-threatening physical barricade in the large bowel. But there is no physical barrier whatsoever. The autonomic nervous system controlling the gut has just given up.
It creates this terrifying illusion because operating on a frail patient who doesn't actually have a physical blockage can be highly lethal.
You're doing a massive surgery for no reason.
Exactly. Subjecting someone to the trauma of major open surgery when their nervous system is already severely compromised, that is a worst-case scenario. Modern medicine had to develop a rigorous classification system to avoid those exact pitfalls. We just don't use the term obstruction loosely anymore.
Right, you break it down into categories now.
We do. We distinguish between a small bowel and a large bowel obstruction. We determine if it is partial, where maybe some fluid and gas can squeeze by, or if it's complete.
And more importantly, the sources emphasize looking at the blood supply, classifying it as either simple or strangulated. Plus, there is this structural classification that seems to dictate how fast the clock is ticking, open loop versus closed loop.
Yes, that structural distinction is paramount. A closed-loop obstruction means a segment of the bowel is sealed off at both ends.
Both ends. So it's trapped.
Completely trapped. Think of a balloon tied at the top and the bottom. Gas and fluid are trapped inside with absolutely nowhere to vent backward or forward. The pressure inside escalates exponentially. It is the single most dangerous configuration because it rapidly accelerates tissue death.
Man, understanding that distinction between a physical barricade and a sleeping nervous system took centuries. The evolution of how we treat this agonizing condition is actually deeply tied to the evolution of surgery itself.
It really is a mirror for surgical history.
Yeah, like the word ileus comes from the Greek word ileos, which literally means twisted or rolled up, which is just such a visceral way to describe that coiling, cramping pain.
Ancient physicians, including Hippocrates, they documented these cases frequently. They recognized the fatal nature of that twisted gut, but their understanding was largely limited to what they could see on the outside of the body.
Because they couldn't look inside.
Right. They would observe a strangulated hernia pushing through the abdominal wall. They could see the trapped, dying tissue, but the internal mechanics were a complete mystery.
The real turning point seems to be in the 18th century with the Scottish surgeon John Hunter. He was studying those strangulated hernias and realized that the ultimate danger wasn't just the blockage of food or digestive juices.
No, it was the blood supply.
Exactly. The fatal blow was the loss of blood flow to the trapped segment of the bowel.
He was really the first to truly articulate the physiology of strangulation. When the tissue gets trapped, it gets starved of oxygen. But knowing that didn't immediately change the outcome for patients because they still couldn't safely operate inside the abdomen.
Right, you just die of infection anyway.
Or shock. It took the invention of anesthesia in the 1840s and then Joseph Lister's pioneering work in antisepsis in the decades following to actually allow surgeons to safely open the abdominal cavity.
So they could finally get in there and fix it.
Exactly. Only then could they untwist the bowel, remove tumors, or repair internal hernias without the patient dying on the table.
But this creates a massive medical paradox, which blew my mind. Before modern surgery, if you had a bowel obstruction, it was almost entirely due to a hernia or a tumor. But because we now perform millions of routine, life-saving abdominal surgeries, we have completely altered the epidemiology of the disease.
We really have.
The body's natural response to surgical trauma is to heal by creating internal scar tissue, which forms these fibrous bands called postoperative adhesions.
We essentially engineered a brand new cause for the disease. In industrialized nations today, postoperative adhesions are the leading cause of small bowel obstruction.
That's crazy.
The surgeries designed to cure appendicitis or remove inflamed gallbladders or deliver babies via C-section, those are the primary reason people return to the emergency room decades later with a barricaded gut. The medical intervention itself creates the mechanical vulnerability.
So let's trace what actually happens when one of those vulnerabilities gives way. We know a fibrous adhesion or a twisted segment can build a dam, but we need to look at the internal machinery once that dam is in place. And this requires grasping the sheer volume of traffic in the gut.
Right, the highway analogy.
Yeah. The human digestive tract processes 8 to 9 liters of fluid every single day.
Which is a staggering volume of liquid when you really picture it.
It really is. And most of that isn't even what we drink. It's roughly a liter of saliva, 2 liters of gastric juice from the stomach, bile from the liver, and liters of pancreatic and intestinal enzymes.
Your body is busy.
Yeah. The gut is managing a continuous, roaring river of secretions that it pushes forward and reabsorbs further downstream. So when that river hits a concrete barricade, the resulting cascade is incredibly destructive.
And that cascade happens in a very specific sequence. The initial phase is all about upstream damming. Above the blockage, gas, which is primarily swallowed air combined with bacterial fermentation, and all those liters of fluid just begin to pool.
They have nowhere to go.
Nowhere. And because the bowel wall is constructed of smooth muscle, its immediate reflex is to fight the obstruction. It begins contracting with immense force, trying to just push the backed up contents past the barricade.
Which explains the clinical symptoms. This is why a patient experiences those intense waves of colicky, cramping pain.
Yes.
And if a doctor puts a stethoscope to the patient's abdomen during this phase, they hear these hyperactive, high-pitched, rushing bowel sounds. The medical term in sources is borborygmi.
Borborygmi.
It is literally the audible sound of the intestinal muscle working in absolute overdrive.
But that muscular effort inevitably fails against a true mechanical block. The ongoing accumulation of fluid and gas forces the bowel to literally balloon outward. And this progressive distension is where the condition becomes mechanically dangerous.
Because it stretches too far.
Because the wall of the intestine is packed with a delicate network of blood vessels. As the bowel stretches, the rising pressure inside the intestinal tube begins to compress those vessels.
Ah, okay. And because veins operate at a significantly lower pressure than arteries, the veins are going to get squished shut first.
Exactly. The arteries, which are pumping blood at high pressure straight from the heart, they stay open longer.
So arterial blood is constantly being pushed into the bowel wall, but the venous return is blocked off. The blood can't drain away, causing the tissue to become massively congested, swollen, and leaky.
And that swelling triggers a profound systemic crisis known as third spacing.
Okay, I have to say, I found the concept of third spacing completely fascinating.
It's a really strange phenomenon.
It is. Because of that leaky, congested bowel wall, all the fluid that your body would normally recycle back into the bloodstream begins weeping out into the tissue itself. And then it leaks into the empty peritoneal cavity inside the abdomen.
Right.
It means a patient can be in clinical shock, suffering from severe, life-threatening dehydration without having lost a single drop of fluid outside their body. Like no sweating, no bleeding, no vomiting required to induce shock.
It's incredibly dangerous. The fluid has basically relocated into a biological no man's land, a third space, where the circulatory system simply cannot access it. Blood volume plummets, blood pressure drops, and vital organs are suddenly deprived of adequate perfusion.
So you are profoundly dehydrated, but internally.
Yes, this is why aggressive intravenous fluid resuscitation is the very first step in managing an obstruction. We have to refill the vascular system before the kidneys or heart fail.
But the IV fluids don't fix the underlying pressure cooker, right? Which brings us to the final fatal stage of the cascade. If that internal pressure continues to rise, which happens incredibly fast in a closed-loop obstruction where neither end can vent, the pressure eventually gets so high that it overpowers even the high-pressure arteries.
And that is the tipping point. Arterial blood flow ceases entirely. The bowel wall is now completely deprived of oxygen. The tissue undergoes ischemia, which rapidly progresses to necrosis or cellular death.
And dead tissue just falls apart.
It loses all its structural integrity in tears. That perforation spills massive quantities of highly concentrated intestinal bacteria directly into the sterile abdominal cavity, triggering peritonitis and overwhelming sepsis. The plumbing problem becomes a fatal systemic infection.
Tracing how that tissue dies really gives you a deep appreciation for the specific ways a blockage can initiate. It is not just a simple clog. Looking at the case types in our sources reveals some truly bizarre mechanical geometry.
Oh, absolutely.
We already touched on adhesions, but the timeline is the most striking factor there for me. A patient can have a completely routine, uncomplicated appendectomy at age 20. And then, 40 years later, a tiny, silent, fibrous band from that old scar can suddenly shift and kink the small intestine like a garden hose.
The unpredictability is what makes adhesions so challenging to deal with. Patients often dismiss a surgery from their youth as irrelevant ancient history, like, oh, that was decades ago.
Right, they don't even think to mention it.
But inside the abdomen, that scar tissue has been lying dormant for decades, waiting for a micro-shift in the bowel's position to suddenly snare a loop of intestine.
But it's not just old scars that cause this. I was blown away by this rare mechanism called a gallstone elis.
Oh, that one is fascinating.
Right. We usually think of gallstones causing pain in the gallbladder itself. But in this scenario, a massive gallstone literally erodes and burns a tunnel completely through the wall of the gallbladder and directly into the adjacent small intestine.
It creates an abnormal connection, a cholecystoenteric fistula.
Yeah, and then the giant stone drops into the gut and just tumbles down the digestive tract until it wedges itself at the narrowest point, usually the terminal ileum.
It is a remarkable demonstration of how pathology in one organ system can literally migrate to destroy another. Radiologists actually have a very specific set of criteria for diagnosing this on a CT scan known as Rigler's triad.
Yeah, I was looking at Rigler's triad, and the logic of it is brilliant. They're looking for 3 specific signs. First, they look for air trapped up in the biliary tree.
which definitely shouldn't be there normally.
Right, but it happens because that burned tunnel allows gut gas to flow backward. Second, they look for the dilated loops of small bowel, indicating the backup. And third, they hunt for the wandering ectopic gallstone, lodged far away from where it was formed.
The imaging literally tells the story of the stone's journey.
Exactly. Another compelling example of mechanical geometry failing is a sigmoid volvulus.
Yes.
This typically affects the large bowel, most often in elderly or bedbound patients. The sigmoid colon is a highly mobile, redundant loop of bowel near the end of the digestive tract. In a volvulus, that loop literally twists on its own mesentery, its own attachment point like wringing out a wet towel.
Which instantly creates a closed loop obstruction.
Instantly. It seals the pipe at both ends and twists off the blood vessels simultaneously.
It is a purely mechanical catastrophe. On an X-ray, the trapped gas in that twisted loop expands enormously, creating a classic, unmistakable shape that radiologists call the coffee bean sign.
Because it looks exactly like a coffee bean.
It looks like a gigantic, inflated coffee bean dominating the abdomen. No tumors, no scar tissue, just the bowel twisting itself into a surgical emergency.
With triggers this varied, ranging from decades-old scar tissue to migrating gallstones to twisted loops of colon, it is no wonder the clinical management is so heavily debated. Navigating a bowel obstruction requires surgeons to confront one of the most high-stakes dilemmas in their field: the watch versus cut debate.
It really is a profound clinical challenge. Because adhesions are the primary cause of partial small bowel obstructions, we know that many of these partial blockages will actually untwist or resolve on their own with conservative management.
It's just giving the body time to sort it out.
Right. The treatment involves giving the patient absolute bowel rest, pumping them full of IV fluids to counteract the third spacing we talked about, and inserting a nasogastric tube down the nose and into the stomach to literally suck out the liters of backed up gas and fluid.
Decompressing the system from the top down.
Exactly.
So the debate exists because surgeons will often want to watch a patient on this conservative therapy for 24 to 72 hours, hoping the kink resolves without the need for another surgery.
Because if you cut them open again, you're just going to cause more adhesions down the line, feeding the cycle.
Right, creating tomorrow's problem to fix today's. But the terrifying risk of watching and waiting is that you might be observing a closed-loop obstruction that is silently strangulating on the inside.
And the margin for error is razor thin there. Strangulation can progress to absolute bowel necrosis with minimal outward changes in the patient's symptoms during the early stages.
That's the scariest part.
It really is. The pain might even temporarily improve as the bowel wall dies and the nerves start firing.
Wow. So they feel better, but they're actually dying.
Yes. That is why surgical teams obsessively monitor secondary markers. Subtle spikes in heart rate, low-grade fevers, or rising lactate levels in the blood, which indicate that cells are dying from oxygen starvation. They are hunting for the quiet signals of tissue death before the bowel ruptures.
This high-stakes environment also highlights some dangerous public misconceptions. I think most people intuitively assume a blockage is caused by diet like eating a massive unchewed steak, or simply suffering from severe constipation. But a true bolus obstruction, where poorly chewed food blocks the gut, is incredibly rare.
Very rare. The real culprits are the structural changes. The adhesions, the hernias, the tumors. Conflating severe constipation with a mechanical obstruction is an incredibly dangerous trap.
Because it delays care?
It delays care and it leads to bad decisions. Patients assume their painfully distended abdomen just requires a strong laxative. But if there's a mechanical barricade in place, taking a stimulant laxative forces the intestinal muscle to contract even more violently against a brick wall.
Oh, that sounds agonizing.
It dramatically worsens the pain, accelerates the pressure buildup, and can actually hasten a perforation.
And we have to circle back to the Ogilvy syndrome pitfall, because that is another huge misconception on the clinical side, mistaking a functional nerve shutdown for a physical barricade.
It happens.
If a surgical team misinterprets that massive colon dilation on the X-ray and rushes a frail, sick patient into an operating room for a major abdominal surgery, they're exposing that patient to massive, unnecessary trauma. All the patient actually needed was a medication like neostigmine to chemically restart the autonomic nervous system.
Or a colonoscopy to simply vacuum out the trapped air.
Right.
It underscores why precision in diagnosis is everything. You have to understand the specific pathophysiology, whether it is a mechanical barricade, a functional failure, an open loop, or a closed loop, because the wrong intervention can be just as fatal as the obstruction itself.
When you look at the sheer scale of this issue, The relevance becomes undeniable for anyone listening, because postoperative adhesions are the leading cause of this crisis. Anyone who has ever undergone an abdominal or pelvic surgery carries a lifelong latent risk.
That's right.
Add to that an aging population where colorectal cancers, which often first present as a mechanical blockage, by the way, and conditions like vulvulus are becoming more common, and this becomes a critical issue for public health and elder care.
Taking all of this into account, the research leaves you with a truly provocative question for the future of medicine. If the primary cause of this devastating mechanical failure is the scar tissue left behind by our own life-saving surgeries, what happens when we engineer that out of the equation?
That's a great question.
Imagine a future where we develop advanced biomaterials that allow internal tissue to heal with zero adhesions. Or, imagine nanotechnology capable of entering the abdomen and dissolving fibrous bands without ever making an incision.
That would change everything.
The very concept of a mechanical bowel obstruction could eventually become a historical footnote. But it also leaves us with this profoundly humbling thought. Our medical history is literally stitched into our anatomy. A life-saving intervention from your youth, like a routine appendectomy, can leave behind a silent, invisible biological tripwire, a tiny fibrous band that could abruptly turn into a surgical emergency decades later.
Wow.
It proves that our bodies are living, shifting landscapes that never truly forget their past traumas.
It is an incredible thought. The idea that our internal landscape holds on to our past like that, and that we could one day render this catastrophic plumbing failure entirely obsolete.
Until then, you really have to pay attention.
Definitely. Until then, it is vital to respect the complexity of that massive rushing highway inside you. It processes a staggering volume of fluid every day, entirely reliant on a delicate balance of smooth muscle, pressure dynamics, and unobstructed space. When that balance fails, the consequences are immediate and profound. Understanding how the transit system works is the very first step in knowing how to protect it.